Well, good afternoon, everyone. It's Dr. Alma Nenshi, and I'm presenting from the Chiropractic Wellness Clinic. And today's topic is about headaches and migraines. And I'm very excited to be able to present this to you. It's a very special presentation for me, this topic is, because when I was a child, I used to get a lot of headaches and migraines, and no one was ever able to help me with them. And it was only when I was, in my teens that I ended up going to a chiropractor who gave me my very first adjustment. And that is what made such a huge impact in my life to decide from, I think, age 12 or 13 that I wanted to do this as a profession, that I wanted to help people who had pain and who never really found results anywhere else. When I was a child, my parents took me to various different specialists, medical specialists, who did a gamut of tests, and nobody was able to find anything wrong. And my pediatrician eventually just called my parents into a meeting and said that I was making the whole thing up because I didn't want to do my homework. And that was a real challenge for me, because we all knew that this was a real concern, and we didn't understand why people didn't recognize what I was going through. So one of the things that I want you to understand in this webinar, it's a little bit about what causes headaches and migraines. And then I would like to go into some of the unique things that we do in the clinic that might be able to help you understand where the headaches are stemming from, and whether it's something that needs attention in a clinic like mine, or whether it needs to be managed elsewhere. So I'm hoping that you all will enjoy this webinar, and it is being recorded as well. So the recording will be posted on YouTube sometime later today or tomorrow. So if you know anyone who you think would have benefited from this webinar and they weren't able to attend, you'll have an opportunity to forward them the link, and then they can listen to it on their own time and hopefully learn some information to help them. So without further ado, let's go right into the presentation. And I'm having a little technical glitch. 1 second. Seem to have lost my mouse. Let's turn this guy on. There we go. Okay. All right, so if any of you have any questions during the webinar, please type them into the question and answer box, and then we'll cover these at the end of the presentation. So when we talk about headaches, one thing to understand is headaches come in different, they're different types of headaches. And, oh my goodness, I think my screen sharing stopped. Okay. Would you please type into the Q&A if you can see the screen again? Are you able to see the screen? We'll just do it this way. Wonderful things about Zoom. There we go. My apologies. I hope that you're back on track. All right, as I was saying, headaches come in various different forms, and the technical term for a headache is cephalgia. So it comes from cephal, which is your head, and algia, which is pain. So when you have pain in the head, it's called a headache. And as you can see from this diagram, that there are a number of different types of headaches. You've got migraines with aura. You've got migraines without aura, and that's the visual disturbance that people may have. And there are cluster headaches, which are headaches that are mainly in the eyes. There are tension headaches, there are sinus headaches, and other headaches that can come from more serious problems such as aneurysms and so on. So there's a whole umbrella of headaches when you think about what type of headaches people suffer with. And so while we won't go into all of these, we will cover some of them so you can understand them better. Now, how big of a problem really is this? Headaches are really big. At least 90% of people in their lives will experience some sort of significant headache. And of them, 3% will actually have more than 15 headaches per month. So 75% of people tend to have headaches by the age of 15. So this is something that doesn't just affect a certain population dynamic. It actually is cross-board. And when you look at 3% having more than 15 headaches a month, if you look at the average population of Calgary, Alberta here in 2019, 3% works out to 38,571 people having more than 15 headaches a month. That's a lot of headaches, and so it is a serious problem that needs to be looked after. The challenging thing about headaches is there really isn't any type of testing or anything that can confirm whether someone has a headache or not. It's really, the diagnosis comes from the patient's history and their presentation. So what you report as a patient using questionnaires and whatever you're feeling that you write down and you tell your practitioner, that's how we're able to diagnose what type of headache you have. So it's completely subjective. Now, there are some technologies out there, the QEEG and PET scans and functional MRIs. They may all show evidence of having cortical dysfunction. But these are quite expensive, and they don't really offer, apart from the fact that you have some sort of dysfunction in your cortex, it doesn't give you any type of therapy parameters or any opportunity for treatment based on what we learned from the testing. So there are certain headaches that I think are important to know about because they can be very serious and can be life-threatening. And we need to know that we have to react if you ever have any of these types of headaches. First of all, if you're experiencing a headache for the very first time, that could be something that might be a life-threatening emergency. If you experience a headache after feeling a pop in your head, or the headache comes on within 1 to 3 seconds very rapidly, you have an intense pain in your head, or you lose function in your body or cognitive function in addition to having your head pain. These are all signs that there might be something else more serious going on. And of course, if that's happening, what do? Call 911. So I think that that's very important. And if you can share that with your family, if you too tend to have headaches, sharing them with your family would be a good thing to have them have these 4 things to look out for them. That having a headache that is different than your normal headache would also be something to be careful about. So when you're looking at headaches and migraines, often we want to figure out what exactly is the difference, right? So we're going to go into a group of different types of headaches. Now, I'm going to look after the migraine first, and that is when you tend to have a one-sided headache. It's usually throbbing in nature. It lasts several minutes to several hours, and it kind of has a global general effect in the whole area of your head. When you're looking at a migraine compared to other headaches, looking at the sinus or allergy ocular headache, these headaches are centered around the sinuses, and you have intense pain that are in the cavities where you have sinuses in your head, and where fluid can accumulate. The tension headache is more like a squeezing band that sits like a headband around your head, and sometimes it radiates from the back of your neck up to the forehead region. And then when you're looking at cluster headaches or occipital neuralgia, this is when you have almost like a poker in the eye, a very concentrated, sharp pain that's in the eye that can affect how your vision and can be quite intense and uncomfortable. So look at your symptoms first of all. Okay, so one of the basic things you can see is your headache pounding or throbbing? Or is it more of an ache or a pressure? So you can work through the flow chart, right? If it's a pounding headache, is it on one side of the head? Well, yes, if it is, it's usually a migraine. If it's not a pounding headache on one side of the head, let's look at some of the other symptoms that are out there that you're experiencing and see if we can correlate whether they actually fall into more of a general headache or if they fall into migraine category. So the flow chart is really helpful in trying to help a diagnostician, a clinician be able to identify what type of headache our patients are having. Migraines tend to be, as I said before, unilateral. They're one-sided, they're pulsating, they're moderate to severe intensity, they last 4 to 72 hours, and they're often accompanied with other types of sensitivities like nausea, or you're sensitive to light, or you're sensitive to sound. And these tend to be migraines without aura. Now, 20% of patients have migraine attacks that are preceded by a short-term visuological or neurological symptom. And this is called an aura, or a migraine with aura. You have a warning sign to your headache. So most often, the auras are visual disturbances and, things like that. But they can involve other senses, and occasionally you can have dizziness or motor and speech deficits that can be part of that as well. And migraine has a strong genetic component. So when you're looking at migraines with aura, they tend to have a higher genetic component, up to 50% for genetics, versus those without aura. But migraines tend to be hereditary. You can have migraines without a headache. And this is an interesting concept because most people think a migraine is a headache. Actually, a migraine is something that's happening in your brain, and one of the side effects is the headache. But if you don't have a headache, you can still have a migraine. So you may notice dizziness, slurred speech or incoherent speech, numbness and tingling, paralysis, tinnitus, which is ringing in the ears, or shaking, vomiting, blurred vision. These are all symptoms of migraines without actually having a headache. Now, this is a really great video, and I hope that you're going to be able to hear it. I'm going to try and play this, and I hope that you'll be able to hear it. I'll put my volume on really loud, and hopefully you'll be able to hear this. If not, just be patient, and I'll send you the link afterwards so that you can watch it on your own.
Well, a very heavy rotation tonight. You had a very like, let's go ahead, Paris, take you through that.
So if you notice there, that person, you couldn't understand a word that they were saying, and it was very incoherent, and you couldn't understand any of her speech at all. And that would be a migraine without a headache. She was having a migraine because it affected all of these components neurologically, but she didn't have a headache. So that would be an example of someone who experiences a migraine without a headache. So what do we exactly know about the neurophysiology of headaches and migraines? We know that headaches are caused either mechanically, there's chemical components, there could be hormonal aspects involved, neurological for sure, Then there are physical stresses that we may have on our body. There are vascular challenges that might be happening with our circulation that can predispose us to migraines and headaches. Ocular challenges, and underlying tone of inflammation in our body. So these are all things that can contribute to headaches. And what would be interesting now is to understand how this face pattern happens in the headache. Sometimes people have pain in the face associated with the headache, and that's because there is a nerve that's in our brainstem. It's the fifth nerve in our brainstem. It's called the trigeminal nerve. And as you can see in this picture, that there are branches of how the nerve, it's trigeminal, means three twins. It means that you've got three branches of this nerve that can affect different areas of the face that are shaded there for you to see. So sometimes we can trace it back very specifically to a specific nerve that is causing the pain. And that is very interesting neurologically when we work with patients that have a specific distribution. It's very interesting to see some of the changes we can see with them. So the trigeminal nerve, which is in the brainstem, actually there's a connection of it down into the neck. And sometimes pain can be experienced like phantom headaches. You can have tension in your neck that causes these phantom headaches in your neck. Also, there is a nerve that's in the back of your neck called the occipital nerve, and it runs very close to the rectus capitis posterior minor and major muscles. And that nerve also joins in with the trigeminal nerve, and sometimes people can get head pain that resembles tension headaches, kind of like in this diagram, for how the different areas of your head and your neck can be affected when you have a headache. So the cause of migraines is thought to be very similar to headaches in general, however, perhaps more of a neurological basis. So the mechanism of a migraine, really, we don't know. There's some data that says that it could be a brain disorder that is causing headaches. But the current understanding is it's fairly unknown what causes migraines, and we talked about, vascular and neurological mechanisms briefly earlier. That could be some of the theories behind what is happening with the migraine. If you look at it from a neurological perspective, you can consider a migraine similar to a seizure, that you have an unstable area of the brain that suddenly becomes hyperactive. So it's firing all the time. And that spreads to other areas, and that can last for minutes to hours. So initially you see increased regional blood flow in the area, so increased blood flow in the area that's hyperfiring, which means that globally the other areas of the brain have decreased blood flow. And vasoconstriction is basically a term that means your blood vessels become narrow. And, there's a sodium and calcium equilibrium change that also happens within the cells. So in phase 2, you start noticing that you have decreased blood flow, and the vasoconstriction is the narrowing of those arteries that are restricting how much blood is passing through them. And of course, then there are chemicals released from cells that cause the rapid vasodilation, or the arteries then becoming dilated or making more room. So that kind of contributes to this pulsing, constriction, and dilation event that happens when you're having your migraine. We also know that when you're dealing with pain is perceived in areas of the brain in the trigeminal and opioid centers, and that there's also an area that's hormonally related, the autonomic nervous system, that is also involved with migraines, and that is from the hypothalamus and how it sends signals down into the brainstem that helps to control hormone regulation in our body. So not only are you activating the pain centers and the opioid centers in your brain where you perceive pain, but you're also activating these hormone centers that are releasing hormones throughout our body. So one of the things that I thought was very interesting in the research is they compared patients who had migraines with vertigo. And they found that significantly more patients who have migraines also report that they have vertigo. And vestibular migraines are usually spontaneous vertigo type of attacks where you suddenly turn your head or you have a head motion that causes the spinning. And that can last from anywhere from 5 minutes to 3 days. So when people have a headache and they have vertigo, sometimes that can be classified as a vestibular migraine. And you can look at vestibular rehabilitation as some of the therapies that can be applied that can help these individuals who have the vertigo to calm their headache pain at the same time as addressing the vertigo. So the other thing that we can note here is this is just a test that showed that there are people who had migraines compared to a control group, and they found that clinical neurological symptoms are common in people who have migraines. So you're doing any type of video oculography, which is basically movement in the eyes and examining that, examining posturography, balance. These sorts of things were all found to be a higher incidence of them being slightly abnormal in migraine groups versus people who did not have the migraines in the control groups. So when it comes to training and treatment, looking at training people who have balance issues, how can we improve their balance? How can we improve their vertigo symptoms? How can we improve dizziness? Those therapies that target those particular areas can have an effect on the pain intensity that you're experiencing with your migraine. So I think that's really exciting. So this is a great picture. You know, historically, way back in the old days, people who had headaches, they found that if you just drill holes in your head and let the pressure out, the headaches would cease, and perhaps, you know, life would cease as well. So, I mean, prehistorically, people had different ways of trying to relieve headaches. And, you know, this isn't what we want to do nowadays, but it's something that people experience when that pressure is so intense in their head. What can we do to try and get rid of it? And that is, you know, certainly wanting relief from that intensity, that throbbing, you know, an immediate relief as fast as possible. You know, it's something that's very common today. So some of the medical treatments for migraines, you know, we have NSAIDs, which are non-steroidal anti-inflammatory drugs. So these things can help to reduce inflammation. So by reducing inflammation, if the inflammation is one of the reasons why you have the headache, then perhaps that might help. 20 to 30% of patients don't respond to basic medical therapies such as NSAIDs. And most people find that even if they do respond, that the problem comes back. And so there are other agents that are there to help deal with migraine pain, other medications that are stronger or address different aspects of brain function. And again, these are also not very satisfactory in terms of their clinical outcomes. So the treatment of migraines tend to still be a puzzle in trying to figure out what is really going to work for people. There are non-pharmaceutical approaches as well. And of course, I'm very interested in that, in my profession especially. because this is what really helped me when I was a child. Is I had a non-pharmaceutical approach. I was popping NSAIDs like they were candy when I was, 11, 12, 13. And, all of a sudden seeing someone who could help diagnose where the problem was coming from and be specific with their therapy, within just a couple of seconds, my headache was completely gone, and it was a miracle for me. So there are some very effective ways of trying to help non-pharmaceutically to help people who have migraines, and they may be effective for you as well. Lifestyle things that you can do if you know that there are triggers. Triggers for migraines might be red wine or other types of alcohol. It might be fermented, like really strong cheeses, or sometimes you can have citrus that can trigger a migraine, or the reflection of the light off the snow when you're driving. These are all things that can trigger migraines. And if you know what these triggers are and you try and avoid them, that's one way of trying to avoid your migraine, logically. Reducing your sleep, having regular meals, and having regular exercise, you have a regular routine, can also help to manage your migraines as well. It's when you have disruptions in your regular routine that there's a sensitivity or a trigger that happens in the brain that says, I'm not used to this suddenly happening. And so there is a hyper reaction sometimes that can happen in the brain that can trigger migraine. So having regular schedules is very important with your meals, with your sleep, with your different activities in your life. And again, as I had mentioned earlier, vestibular rehabilitation has shown to really help people who have migraines, especially those migraines that are accompanied with dizziness and vertigo. So if we address the dizziness and the vertigo and the other vestibular components and try to rehab that shows, or that seems to show an improvement in the intensity of the migraines that people are experiencing, the migraine pain. So let's talk about how we tend to do this in clinic. So first of all, it's very important when a patient comes in with something like a migraine that we take the time to do a full brain investigation. So I'm not going to dissect your brain, obviously, but I think it's important to understand different functions of how things are working in your brain. Your brain has different areas that are involved with inhibiting pain. And there are certain examination findings or examination procedures I can do to see how well those areas of the brain are functioning. So if I want to look at the PAG, or the periaqueductal gray area, I can test to see how your eyes jump from target to target vertically up and down, and those are called saccades. Similarly, other areas you can evaluate based on breathing and the expansion of your ribs. Are they expanding symmetrically or asymmetrically? Head and eye movements and coordinated movements, you can examine those. And if there's any asymmetry or any things that you find that are not just quite right, you can use that to give us some information on perhaps the rostral ventral medulla might be affected there, or the PMRF, the pontomedullary reticular formation, that is highly integrated with the autonomic nervous system, how stress impacts your body. Do you have excess tone in one side of your body versus the other? Do you have asymmetry in how you perceive sharp dull sensations, such as if I ran a pinwheel on your skin? Is it feeling different from side to side? So we can use our clinical examination to isolate different areas that may be controlling whether you can inhibit pain. So when your migraine is happening and your pain inhibitors are not working well, then you'll feel the full expression of that migraine. But if the pain inhibitors are working, then you can have a migraine and not necessarily feel the headache pain with it. So I think that that's really important to understand, because sometimes people think, I have a migraine because there's a Chinook and the Chinook is causing my migraines. Well, I'm sorry to say, if the Chinook caused migraines, then everybody in Calgary would have a migraine on the day of a Chinook. So the Chinook doesn't cause migraines. It may be a trigger, a pressure trigger or something in the environment that is triggering your migraine. But your ability to inhibit pain by dampening activation of these cells called nociceptors in our body, that is what's going to determine how bad your migraines are going to be and if you can overcome them. So here's a quick test that you can do at home. So tissue perfusion test is basically a squeeze test. So you look at the bed of your fingernail, your thumbnail, and then you just press on it. And you press on it for a couple of seconds, and then you let go, and you see how quickly that thumb turns pink again. So when you squeeze it, it turns white. And then when you let go, the white should turn back into pink. And then you do it on the other side, and you see if it's symmetrical. So we want that to be fairly quick, within 1 to 3 seconds at the most. And you want that to be symmetrical. So the timing that the tissue perfuses should be the same on both sides. And pupil response, how quickly do your pupils react when you shine a light into them? This is something that perhaps you may not be able to do, but it's something that if you had a partner, they could gently shine a light from the side into your eye and see if your pupil constricts quickly or not. Or is it something that doesn't react at all? And then red saturation is when you look at something that is red, and I'll just put up my phone here so I know it's not quite red, but let's say this is red, and you cover your eye up and you look at the color of your phone, and then you compare it with when you cover the other eye. And this tests to see how your optic nerve is working and if there's any inflammation in the optic nerve, which is the nerve that sends information from your eyes to your brain. And sometimes what you will find is when you cover one eye, the color of the red for that object is brighter compared to when you cover the other eye, or you notice different tones of that. So I think that that is something that you can do at home to see if there's any asymmetry in how different receptors in your brain or that are sending information to your brain. If there's asymmetry in that, we can try and investigate that further. Breathing, of course, is so important, right? We want to make sure that we can regulate our body's pH by having a healthy amount of oxygen. And some people just breathe from their shoulders, whereas you should be breathing from your abdomen. So better breathing means you have better stability. And again, the breathing mechanics are important to investigate because we want to see one of the areas that control pain also controls breathing. So if your breathing is off, maybe your ability to control pain will be off as well. And so that's why we check for breathing. Head and eye movements, naturally when you hear a sound to the side and let's say you snap your fingers, your eyes will go, and then what do you reflexively do? You look at what you're looking at, right? So your head and eyes should move symmetrically at the same time together. And we have certain development in our cortex that if I snap my fingers, I can train my eyes to actually look in the opposite direction or turn my head in the opposite direction. So there are different ways to override this instinctive tendency to turn your head to the right. But sometimes people don't have those patterns, and so those are important for us to understand. So again, we can link them back to areas of your nervous system that are responsible for modulating pain. So one of the things that I really wanted to go over is what are some of the things that can be done in order to help people who have headaches, who have migraine headaches. And so in our office, we've got a bunch of things that we do. So first of all, we have to do a physical exam. You check your vitals to measure your circulation and all of that, and your respiration. You check balance. You check how your eyes are tracking. You check the vertical saccades, where you jump from target to target. And then you check coordination. You know, there's different areas of your brain that have different responsibilities. So you want to check to make sure that things are coordinated properly. Coordination could be hand-eye coordination or any of that. Cognitively, we want to make sure that everybody has good cognition, and then physical examination, of course, of the areas that are affected, and we do a full neurological workup. So when we're talking about autonomics, right, when we're talking about stress, and we're talking about hormones, these are all things that can impact your symptoms and your pain. And so some of the treatments that we do obviously are geared to try and help challenge that imbalance to try and get it more neutral. So we might use ice water to try and reduce heart rate. We may try and obviously we do cervical adjustments because there's a huge amount of research that shows how neck adjustments can help with headache pain. Also, there's your vagus nerve, which is your nerve in your brainstem that is responsible for helping you come away from stress. It controls your digestion and your reproduction, and it's your anti-stress nerve per se. So trying to stimulate that using various therapies. There's auricular therapy and breathing exercises, abdominal and visceral adjustments, gentle adjustments that we can do in the abdominal regions to try and help balance the autonomic. So these are some of the treatment applications that we do in our clinic. And when we help to balance them, then we see that there's a change in the intensity of pain that someone can experience because it's treating not just the symptom of the pain, but it's treating the mechanism, what area is affected when the pain intensity is not modulated. Similarly, there are other treatments that we do neurologically, such as mirror therapy. There's acupuncture that can help with headaches. Frequency-specific microcurrent helps with reducing inflammation in the body. So if there's an inflammatory component, getting those therapies really help with that. ARP wave neurotherapy, peripheral field localization, hand identification, facial recognition, memory recall. These are all just a list of different things that we do. Some of you may understand some of these therapies if you've been in clinic and have experienced them, and others you may not be familiar with, and that's okay. Just to know that there are options available. We use the senses, using light and sound and smell. Trying to train language reading and comprehension can help with the temporal lobe, and trying to stimulate the temporal lobe to have an impact in overall brain function. Planning and sequencing activities, using sensory integration. Impulse control is good too, right? Where you can clap a pattern and you can have your patient respond by clapping the same pattern back. And if you say, I'm going to clap once, every time I clap once, you clap twice, it becomes a game, right? Or if I clap twice, you clap once. You want to see if they're able to control their impulse to mirror your activity. So that's something that is really great in helping to activate certain regions of the brain. Of course, we train balance. We check to see if there are any eye muscles that are not strong, and we try and strengthen your eye muscles. We do vestibular rehabilitation. We try and help with coordination activities, cross-crawl exercises. We have an interactive metronome that we have in the office that helps with timing and sequencing in the brain. Looking at primitive reflexes, and there's so much that can be done. So I just kind of gave you a list of some of the unique things that we do in the office that may be different than what you would find in other clinics. So what's a plan, right? We need to pay attention during the examination to figure out what areas are off balance. And once we figured out what the areas are that are off balance, then you can say, okay, let's set out some realistic, measurable goals that we can work with. So when we apply our therapies, those findings that were off balance, if we retest them at a later date, we hope that they would be more balanced. So we need to look at trying to help people with migraines by not only just monitoring their symptoms in terms of the intensity and frequency of their headaches, but we also need to look at other findings in our examination and see if those findings neurologically improve as well. And then we'll be able to get a better idea of whether our treatment applications are actually working or not. So when we're talking about doing something from a treatment perspective, you have those patients that come in when they have a symptom, they get a treatment, they feel great, and then later on when they have symptoms again, it could be a week, it could be months later, they come back and you get another treatment. So you just kind of manage the symptoms. But what I have found is you don't have to live with your symptoms. You can have a more intense course of action where you can combine various different types of therapies so that you have a compound effect. And that's how you increase intensity. You increase intensity by not just doing a basic chiropractic adjustment, but combining that with vestibular training, combining that with increasing, other types of sensory stimuli like smell and vision and taste, and trying to look at the whole body as a whole rather than just one area. So I think when you combine therapies, they have a greater effect together. 1 + 1 isn't 2. 1 + 1 ends up being like a million, right? We want these therapies to layer and help improve the overall function of the central nervous system. So using multiple therapies together increases the intensity. Now, we talked about patients coming in whenever they have pain, and that's okay too. You don't have to do it that way. But if you want to see greater results and maybe longer lasting results, layering approaches seem to work better clinically when I see that in practice. The other thing is frequency also makes a difference too, right? So if you come in once a month or once every 6 months for a treatment for just a symptom, you look after the symptom. But if you have your sessions close together so that you're able to build on each one before you reset to where you were before, you can set a new level of function that baseline could be much different than what it was before you came in if you were just coming in on a symptom basis. So for some people who really have a lot of symptoms and they want to see results, we may see them 2 or 3 times a day, and that may happen for a week to 2 weeks. And that way we can do virtually, for some people, that many visits might be a year of care, but you can get all of that within a week or 2 weeks and really show a big difference in how they, it really shows a big difference in how they respond. So that is really important, is having those visits close together. And then if you combine the layering approach with high frequency, that's when you see big results, right? And again, all of these therapies are focused on the assessment, right? What did you find in the examination? What are some of the things that we found that are off balance, that shouldn't be working that way, that we need to help you correct? And are we able to see in a re-examination after we've done a treatment trial, are we able to see those changes on a re-examination? That is so critical, right? So when people have headaches and migraines, you don't really have to suffer. I was blessed when I was young to have been shown this path of chiropractic treatments that helped me with my migraines at a young age that basically changed the course of my life. And there are other people who rely on getting a migraine or getting a headache whenever the Chinook rolls around, or, yeah, I know I'm going to get a headache because my sleep pattern has changed on the weekend versus during the week, or because I had a glass of red wine at dinner, or whatever the reason is. But there are ways that you can increase how your central nervous system is functioning so that you can have better pain modulation, that your brain can work more efficiently so that you are able to live your life in a more functional manner, hopefully with less pain and less frequency of migraines. So for those of you who are on the call that on the webinar that have not come in to do a thorough examination about your headaches and your migraines, I encourage you to give us a call. You know, you can come in, we can sit and have a chat for a little bit and talk about your symptoms and decide whether or not you want to do an intense examination to explore all of these areas and to see if that is something that can benefit you. So if you are interested, please don't hesitate to contact me, and I would be more than willing to help you. So that's all that I wanted to present today in our webinar. I really thank you for your time. You know, there are a lot of different things people can be doing in the middle of a Wednesday afternoon, and I'm so grateful that you've decided to spend your time here with me today. And I hope that some of the information that I covered is something that gives you a different perspective on how you look at migraines and headaches, and maybe even adds to your knowledge base so you understand things a little bit better and how they're working in your body. And of course, if you have someone that you think would benefit from listening to this presentation, please forward them the email that has the YouTube link that they can go and listen to this presentation on their own time. So thank you so much. I really appreciate your time. And I'm going to just head over here. Perfect. Thank you so much for your time.